So briefly, I'll talk a little about hepatitis B different phases. We'll dive straight into the treatment options and spend majority of our time talking about controversies, both starting and stopping therapy. So Hep B classically goes through these 4, if not 5 phases, starting with the initial infection, where patients will have their E antigen status will be positive, their DNA levels will be really high, but they won't have significant inflammation, so the ALT levels will fairly be normal. From this infection phase, their E antigen remains positive and then may enter a hepatitis phase where they'll have active inflammation within their liver. There'll be a lot more cell death. All of this has a lot to do with how Hep B is interacting with our immune system. Okay? Following this, slowly they may actually lose their E antigen and enter another state of stasis, inactivity, where they may return to having chronic infection with normal ALT levels. Their DNA levels may actually drop back down. And then eventually they may flare or have reactivation with their E antigen status again remaining fairly negative, re-entering a chronic hepatitis phase, and slowly losing their surface antigen and entering into a state of functional cure. So this table just re-summarizes everything we just discussed, but highlights the old terminology, which is still, despite being called old, used very commonly in literature. So the first phase we described, where the E antigen status is positive, but the ALT levels are normal, DNA levels are high, is labeled as the immune tolerant phase. And following which, if they enter a chronic hepatitis phase, was previously described as a Hep B E antigen positive immune active state. Following that, once the E antigen is lost, it's labeled as an inactive chronic Hep B phase, and then immune reactivation when the E antigen negative patients enter a chronic hepatitis phase. So what are our treatment goals for majority of the patients? So the most important goal is trying to improve survival with all treatment and addressing quality of life for these patients. But generally, most of the studies focus on either loss of E antigen, trying to prevent cirrhosis or reversing fibrosis, avoiding liver decompensations, and decreasing the risk of HCC. And if possible, addressing functional cure, which is loss of Hep B surface antigen. So among the treatment options, the first-line therapies recommended primarily focuses around our nucleosides or nucleotides with entecavir, tenofovir, alafenamide, or Vemlidy, and tenofovir disoproxil fumarate being the key first options. Pegylated interferon remains as an available option, but should be reserved for select patients due to its side effect profile. It is favorable for patients who are interested in finite therapy over choosing our nukes, which often tend to require long-term therapy. But you should be cautious as pegylated interferon is contraindicated in patients with autoimmune diseases, if they have uncontrolled psychiatric diseases, if they have severe cardiac illnesses, if they have decompensated liver disease, and more. Lastly, the last option available is usually not recommended by AASLD due to high risk of resistance with these medications with lamivudine, adofovir, telbivudine. Other factors to consider when choosing therapy is which treatments have patients previously been exposed to. In particular, choice of entecavir in patients who've had prior exposure to lamivudine should be cautiously done. And same with if patients are older, they have renal insufficiency or bone loss. The newer options usually are better for these patients. So what do we usually look for in patients when deciding whether a patient needs treatment is usually their E antigen status makes a difference. How high of a viral load do they have? And what's going on with their liver? Do they have active inflammation? Usually inflammation is described by their ALT, and do they have fibrosis and cirrhosis? With the newer guidelines, there's been a greater push to use non-invasive methods of assessing for fibrosis and moving away from our old ways of trying to do more and more biopsies. So we'll talk a little more about starting treatment in patients and we'll focus on E antigen status through each of these slides. So this particular slide talks about patients who have a positive E antigen. So most of these patients will have a high viral load, and then you want to look at their ALT levels. If their ALT is normal, this is based off the AASLD guidelines, if their ALT is normal, you can continue monitoring these patients, usually every 6 months. But if their ALT is abnormal or greater than 2 times the upper limit of normal, treatment is recommended. However, in patients who have a high viral load, but their ALT remains between 1 to 2 times the upper limit of normal, usually these patients need closer follow-up, ideally labs done every 3 to 6 months. You should look at other factors. AASLD recommends looking at whether patients are older, whether patients have family history of HCC, do they have hepatic fibrosis, or do they have a secondary reason, a non-liver related reason to be on Hep B treatment. Other society guidelines do recommend looking at a few other factors. Dr. Han and Dr. Kong are big fans of the APSL guidelines, looking specifically at patients' albumin levels, their AFPs during flares, their platelet counts being low, do they have HCC similar to the AASLD guidelines, and then fibrosis per se. There's a scoring system available for this. So among our E antigen negative patients, the viral load cutoffs are a little lower, often because their viral loads are on the lower end. And again, you want to focus on what's going on within the liver. How much inflammation do they have? So if their ALT is less than the upper limit of normal, these patients again can be monitored. But if their ALT is greater than 2 times the upper limit of normal, you should probably treat these patients. Lastly, if they do have a high viral load, but their ALT is 1 to 2 times the upper limit of normal, again, you want to go through the same assessment of patients to see if they have secondary reasons or what other factors do they have where they may qualify for potential treatment. Okay. All right, and then lastly, looking at patients with cirrhosis, a general rule of thumb is the safest one practice is if they have compensated or decompensated disease, doesn't matter, try and treat them. Although the evidence for treating patients with cirrhosis with low viral load and compensated disease is low to moderate, the goal again there is to reduce the risk of decompensation if possible, potentially reverse the fibrosis. And most of the studies do focus and talk about how these patients, when put on treatment, often do have lower risk of decompensation, low risk of developing HCC, and lower liver-related death. However, the quality of evidence there is fairly low. For our decompensated patients, treatment should be recommended. So summarizing the treatment groups, patients who have active inflammation, so defined by their ALT. This is probably one area of controversy, as in normal ALT cutoffs, as defined by AASLD, are up on the board. They're not consistent across different societies. And if you look at our own lab systems, the normal ALT for a UCLA lab is close to 50 to 72, depending on which lab you look at. So this is a key component of the society guidelines, so if you want to look at a tighter ALT cutoff. Patients who have significant advanced fibrosis, patients who have cirrhosis should be considered for treatment. Things that I didn't discuss are co-infections with HIV, HCV, HDV. They should be also considered for treatment. And then there's some unique situations where patients who are on immunomodulator therapy or pregnancy require separate attention. So this next busy table essentially summarizes, I specifically focus on AASLD, but summarizes our other society guidelines. And really, I wanted most of us to focus a little on the variance in Hep B DNA levels. And then all of the society guidelines focus on ALT being a key component, with EASL a bigger proponent for considering biopsies or non-invasive testing. So the last half, I'll focus a little on controversies. And the primary controversy really is, should we be treating our immune-tolerant patients? So I just want to redefine who is an immune-tolerant patient. Really, these are patients who have a positive E antigen, have a high Hep B DNA level, but really have no signs of significant liver disease, as in their ALT is normal. If a biopsy is available in these patients, they won't have significant inflammation, they won't have significant fibrosis. Majority of these patients tend to be on the younger side. Age plays a key role, and I'll go over why in a second, primarily due to HCC risks, okay? And younger patient is defined differently across different societies. AASLD defines a young patient as less than 40. If you look at the European guidelines, usually patients less than 30 are defined as a younger patient. So again, this is the immune tolerant phase early in the disease where their DNA levels are high, ALT levels are normal. So why the controversy really is that high Hep B DNA has been associated with a higher risk of cirrhosis and a higher risk of HCC in natural history studies. So looking at what are the specific risk factors for HCC, age plays a key role. So with each increasing decade in life, their relative risk for HCC drastically increases. So similarly, Hep B DNA levels play a key role as well. So higher your Hep B DNA levels, higher risk of HCC. However, if you try cutting down the studies and looking specifically at the natural history studies that support treatment, okay, They have several small issues with how the study groups were defined. Specifically, not a lot of the studies included true immune tolerant patients. I'm sorry if the slides are a little too difficult to read, but it's trying to highlight that the majority of these studies didn't have true immune tolerant patients, and if they did, the proportion of patients with immune tolerant disease was low, and the ALT levels defined were also variable from study to study. Okay. And then the next thing to consider is, the 7 randomized control trials are currently reviewed by the AASLD, looking specifically for data on whether immune tolerant patients should be treated. So the primary endpoint for these studies was loss of Hep B E antigen, and the treatment available options were either interferon on a fixed level of 48 weeks or our nukes at a fixed duration of 48 weeks. Okay, 5 of the studies were placebo-controlled, while 12 were head-to-head. So the drawbacks of the studies were only 2 studies included patients with normal ALT levels, as defined by AASLD, while the remaining 15 studies included ALT levels that are less than 2 times the upper limit of normal. So these patients don't fully qualify as immune-tolerant patients. And the quality of the randomized control trials were low to moderate, specifically among the 2 studies where ALT levels were less than upper limit of normal, their quality was very low. And the findings when looking through the 17 studies primarily demonstrated that antiviral therapy didn't really help reduce the risk of HCC, cirrhosis, or liver-related mortality. So currently across all major society guidelines, the recommendation for immune-tolerant phase is to monitor. The frequency of monitoring can vary from society to society, with the European recommendations being monitoring recommended every 3 to 6 months, versus an AASLD recommending monitoring every 6 months. All right, in the last 5 minutes, we'll focus a little more about when to stop therapy. So what are our treatment endpoints that we should really be looking at? Here again, the E antigen status makes a difference. So in patients with chronic Hep B who have a positive E antigen, watch for a loss of E antigen. So if patients end up losing E antigen and their DNA levels are very well suppressed on treatment, their ALT levels are normal, treatment can be stopped after a duration of consolidation period. So usually 6 to 12 months of therapy is recommended once the E antigen is lost. And if done so, usually these patients have great durability. 76 to 83% of patients will remain in this phase and eventually lose their surface antigen. However, relapse is fairly common in these patients, so they require close monitoring. They may have elevations in their ALT. They may have elevations in their DNA levels. Usually, 3-month period is recommended for monitoring for these patients. The other alternative for the E antigen positive patients, once they lose their E antigen, is to wait for loss of surface antigen. And once they lose surface antigen, treatment again can be considered to be stopped. Among the E antigen negative patients, these patients are more challenging. So at the start of treatment, if they've already lost their E antigen, usually these patients will require indefinite therapy and may rarely end up losing their surface antigen. And that should be the right time to consider stopping therapy among these patients. You do want to make sure that their Hep B DNA levels are well suppressed and their ALT levels are fairly normal. Again, whenever stopping therapy, it is very important that you try and monitor these patients long term. And in the early part of the endpoint, it's very important that they come in frequently, they do their labs regularly. I'm usually hesitant stopping therapy in patients who are not very compliant or showing up for their annual visits just to get their meds. Okay, so Hep B surface antigen is probably going to play a much bigger role in the newer set of guidelines. Okay, so this study was a major study from 2022, highlighting the importance of Hep B surface antigen when considering stopping therapy. So it looked at, it's a multi-center study, multi-ethnic population, greater than 1,500 patients were enrolled in the study, and patients were primarily chronic Hep B patients with E antigen status being negative, with well-suppressed DNA levels and normal ALT levels, and their nukes were withdrawn. So these patients were not on pegylated interferon. On withdrawal of nukes, their cumulative incidence of losing their surface antigen at 1 year was around 3%, and at 48 months, so about 4 years, was around 13%. And highlighting more specifically, by race, so looking at Caucasians, if their Hep B surface antigen levels were less than 1,000, their probability of losing surface antigen was close to 40%, while among Asians, if their Hep B surface antigen levels were less than 100, their probability of losing Hep B surface antigen was close to 30%. Now, less than half of these patients did go back on treatment. They did include patients with cirrhosis. There were around 11% of the patients had cirrhosis. Reinitiation of treatment, e-antigen status didn't make a difference in these patients. However, among patients who did develop decompensations after stopping therapy, cirrhosis was a key risk among those patients. So in summary, the goals of Hep B treatment are to reduce risk of cirrhosis, HCC, and liver-related mortality. Normal ALT definitions do vary among different societies, but remain the key component of assessing necroinflammation. And then true immune-tolerant patients may not be at increased risk of cirrhosis and HCC based on current data. This may change over time. And then treatment may be stopped in select patients with a greater role for Hep B surface antigen with coming time. There's growing potential for a cure, hopefully in the next decade. And with that, I'll hand it over to Dr. Saab.